Hello, my name is Hunter Gibson. In this presentation, I will examine the impact of probiotic supplementation on symptom severity in autism spectrum disorder. Specifically, I will explore prevalence trends, core symptom domains, neurodevelopmental mechanisms, gastrointestinal comorbidities, the gut-brain axis, and 5 clinical studies evaluating probiotic interventions. I will conclude by discussing cross-study patterns, limitations in the literature, and implications for holistic health practice. So why does this matter? Autism spectrum disorder is a neurodevelopmental condition characterized by persistent differences in social communication and patterns of restricted or repetitive behavior. Over the past 2 decades, prevalence rates have increased dramatically. Current surveillance data indicate that approximately 1 in 31 children are diagnosed. Whether this increase reflects improved diagnostic practice, broader criteria, environmental influences, or multifactorial contributors remains an area of ongoing debate. Regardless of the cause, the growing prevalence makes it essential to examine both behavioral and biological dimensions of this condition. In addition to behavioral characteristics, gastrointestinal symptoms are disproportionately common in children with autism spectrum disorder. Many experience chronic constipation, diarrhea, abdominal pain, bloating, or altered stool consistency. In some cases, gastrointestinal distress appears to correlate with behavioral intensity, suggesting a possible physiological behavioral interaction. Emergent microbiome research demonstrates that children with ASD frequently exhibit differences in gut microbial diversity and composition compared to their neurotypical peers. These findings have led researchers to investigate whether modulation of the gut microbiome may influence both gastrointestinal and behavioral outcomes. Before we start, it's important to understand exactly what autism spectrum disorder is. Autism spectrum disorder exists along a wide spectrum of presentation and severity. Symptoms typically emerge in early childhood, often before 3 years of age. Core features fall into 2 primary domains. First, persistent differences in social communication and social interaction. These may include difficulty with reciprocal conversation, challenges interpreting nonverbal cues, limited eye contact, or difficulty developing peer relationships. Second, restricted and repetitive patterns of behaviors, interest, or sensory experiences. These may include repetitive motor movements, rigid adherence to routines, highly focused interest, or hyper or hypo-reactivity to sensory input. Importantly, ASD is heterogeneous. No 2 individuals present identically. This variability reflects complex interactions between genetics, neurodevelopment, immune function, and environmental exposures. If we take a look at this chart, we can see the prevalence and populations affected. According to the Centers for Disease Control and Prevention 2025, prevalence among 8-year-old children has increased steadily over the past 2 decades, from just 6.7 per 1,000 in 2000 to 32.2 per 1,000 in 2022. This represents a nearly 5-fold increase. Let's discuss a bit about the etiological framework. What do we know about why autism happens? Current evidence supports a multifactorial developmental model. Genetic influences play a significant role, particularly genes involved in synaptic formation, neural connectivity, and transcription regulation. However, genes alone do not fully explain variability in presentation. Environmental factors, including prenatal exposures, immune activation, and toxicant exposure, may interact with genetic susceptibility to alter developmental trajectories. One of the most widely discussed neurobiological hypotheses involves atypical synaptic pruning. During early brain development, the nervous system forms an excess of neural connections. Through a process called synaptic pruning, unnecessary connections are eliminated, allowing neural circuits to become more efficient and specialized. If that pruning is delayed or disrupted, excess synaptic connections may remain. This may contribute to altered connectivity patterns observed in neuroimaging studies that may influence sensory processing, cognitive flexibility, and behavioral regulation. This hypothesis offers a biologically plausible mechanism connecting genetic vulnerability, environmental influence, and observable behavioral differences. Common comorbidities. Autism spectrum disorder frequently co-occurs with additional conditions. Psychiatric comorbidities include anxiety disorders and attention deficit hyperactivity disorder. Neurological comorbidities may include epilepsy and intellectual disability. Sleep disturbances are also highly prevalent. However, gastrointestinal dysfunction stands out as one of the most clinically significant comorbidities. Chronic digestive discomfort can influence mood, sleep quality, irritability, and attention regulation. This overlap strengthens interest in investigating gut-mediated mechanisms as potential contributors to symptom severity. Current standard treatment models emphasize behavioral and educational interventions, including applied behavioral analysis, speech therapy, and occupational therapy. These approaches can be beneficial, but they often require early intervention, significant time commitment, and consistent access to resources. Pharmacological treatments may reduce the associated symptoms, such as irritability or hyperactivity, but they do not directly address underlying neurodevelopmental differences. Furthermore, treatment response varies significantly across individuals due to the heterogeneous nature of ASD. These limitations highlight the need to explore adjunctive interventions targeting physiological systems, including the gastrointestinal tract and the microbiome. Let us make the connection between probiotics and the gut-brain axis. The gut-brain axis refers to the bidirectional communication network between the gastrointestinal system and the central nervous system. Communication occurs through multiple pathways: neural signaling via the vagus nerve, immune signaling through inflammatory mediators, hormonal signaling through the HPA axis, microbial metabolites produced by gut bacteria. Gut microbes influence production of neurotransmitters such as serotonin, dopamine, norepinephrine, and gamma-aminobutyric acid, or GABA. Here we can see that a substantial portion of serotonin is synthesized in the gastrointestinal tract. Microbial metabolites, including short-chain fatty acids, can influence neuroinflammation, neuroplasticity, and stress regulation. Alterations in microbial diversity may therefore influence both GI symptoms and behavioral expressions in ASD. Let's discuss the rationale for probiotic supplementation in ASD. Across systemic reviews and meta-analysis, probiotic supplementation demonstrates the most consistent benefit in improving gastrointestinal symptoms. Improvements in constipation, stool frequency, abdominal discomfort, and overall GI function are frequently reported. Behavioral outcomes, however, are more variable. Some studies report reductions in hyperactivity, social withdrawal, or sensory reactivity, while others show minimal impact on core social communication features. This variability suggests that probiotic effects may be strain-specific and influenced by baseline gastrointestinal status and individual biological variability. Study 1 was a single-blinded, randomized, placebo-controlled study. The children received 5-gram sachets containing 9 billion colony-forming units of 12 probiotic strains. This product is patented and marketed as NutriNeuron Pediatrix, or a placebo, which was administered twice daily for 3 months. Here we can see that participants demonstrated measurable improvements in gastrointestinal symptoms and selected behavioral domains. Strengths included randomized design and measure of both behavioral and gastrointestinal outcomes. The limitations included short duration and limited long-term follow-up. Behavioral outcomes for this study were measured using the Social Responsiveness Scale 2nd edition, which you can see listed here as SRS-2. Study 2 was a double-blinded, randomized, controlled trial with parallel factorial design with 4 arms. The children received a DSF mixture, which is marketed as Vivomix in the UK and Visobiome in the USA, which had 8 strains of 450 billion colony-forming units per packet. 2 packets a day for 1 month, and then 1 packet a day for 5 months. The placebo matched in appearance and taste and contained 4.4 grams of maltose and silicon dioxide. Both were administered orally in cold, non-carbonated liquid. Results for this study were measured using the Autism Diagnostic Observation Schedule Calibrated Severity Score, listed here as ADOS-CSS. Participants in this study were broken up into subgroups with and without baseline gastrointestinal symptoms. Children with existing gastrointestinal dysfunction demonstrated the most significant improvements in adaptive functioning and sensory processing. This finding suggests that baseline physiological status may influence her responses. Limitations in Study 2 included a small sample size and a dropout rate of 25 to 50%. A large proportion of the dropouts occurred before clinical evaluations began, and a disproportionate amount of placebo participants dropped out of the study as well, which was attributed to parents not seeing a result that they expected. The strengths included double-blinded, multi-domain assessment, a control for current therapies, and high compliance rates. Study 3 was a 3-month prospective open-label study evaluating 30 children with ASD ages 5 to 9 years old, with 19 boys and 11 girls, and 30 age and gender matched controls. Participants in this study received a 1 gram per day sachet containing Lactobacillus acidophilus, Lactobacillus rhamnosus, and Bifidobacterium longum. This open-label study observed reductions in behavioral severity scores alongside improvements in gastrointestinal complaints. Results were scored using the Autism Treatment Evaluation Checklist, which you see listed here as ATEC, and the Global Severity Index 6 domain, which you see listed here as 6-GSI. Although absence of placebo control limits causal interference, the correlation between digestive improvement and behavioral change strengthens the gut behavior hypothesis. In Study 3, we see several limitations such as the small sample size and the single-center open-label design. However, we also have strengths with the assessment of both behavioral and GI outcomes. In Study 4, we move from probiotic supplementation via oral routes to microbiota transfer therapy, which was given either orally or rectally, depending on the participant. This study was also an open-label trial evaluating microbiota transfer therapy in 18 children with ASD ages 7 to 16 with moderate to severe GI symptoms. The treatment lasted 8 weeks with a follow-up extending to 8 weeks post-treatment. Participants in this trial were given an antibiotic pretreatment, a bowel cleanse, and this was followed by a fecal microbiota transplant, or FMT, with a high initial dose plus daily maintenance doses for 7 to 8 weeks. MTT demonstrated substantial reduction in gastrointestinal symptom severity accompanied by moderate behavioral improvements. Scores were measured using the Childhood Autism Rating Scale, or CARS, the Social Responsiveness Scale, or SRS, and the Aberrant Behavior Checklist, or ABC. However, the open-label design and the pharmaceutical pretreatment limit generalizability. Still, the findings provide compelling evidence that altering the gut ecosystem can influence symptom expression. Our final study was a randomized, double-blinded, placebo-controlled trial with a 1-to-1 allocation ratio conducted in Spain. Participants received Lactobacillus plantarum and Lactobacillus brevis. Scores for this study were also measured on the Social Responsiveness Scale 2nd edition, or the SRS-2. The study reported reductions in hyperactivity and impulsivity in younger children with ASD. Effects on core autism features were limited, reinforcing the idea that probiotic benefits may target associated symptoms rather than foundational social communication differences. Study limitations included a small sample size, a mild baseline severity, and a lack of microbiome personalization, while the strengths included a strong randomized double-blind placebo-controlled study design with validated behavioral and neurophysiological assessments. Across studies, gastrointestinal improvement is the most consistent finding. Behavioral improvements are present but heterogeneous. Effects appear influenced by probiotic strain selection, treatment duration, baseline symptom severity, and individual biological variability. Small sample sizes and short durations remain significant limitations across the literature. Clinical implications for holistic health. Within a holistic framework, probiotic supplementation may serve as an adjunctive intervention integrated alongside behavioral therapy, nutritional optimization, sleep regulation, stress management, and family-centered support. Individualized assessment and monitoring are essential. Not every child will respond similarly. Personalized strain selection and ongoing evaluation may improve outcomes. Holistic care recognizes that physiological and behavioral systems are interconnected and must be addressed collectively rather than in isolation. To quote our Santachi et al. 2020 study, the well-known neurobiological heterogeneity of ASD implies that each medication is likely to benefit only a subset within the spectrum of affected children, as suggested by the results of pharmacological trials in this population. In the future, clinical trials could conduct larger-scale, long-term randomized controlled trials. We could develop standardized probiotic strain protocols to reduce the variability seen across studies. We could include biomarker tracking, such as the microbiome composition and inflammatory markers, to better understand the mechanisms. And we could also implement longitudinal follow-up to evaluate lasting behavior and GI outcomes. Within a holistic framework, we could recommend nutrition and gut health. These are things that are often lacking in individuals with ASD due to sensory differences. We know that our nutrition and our gut health are foundational because a proper diet affects our gut microbiome. We could address physical activity and suggest nature therapy. We could evaluate sleep and routine since we know that sleep issues are present in a lot of individuals with ASD. We could incorporate mind, body, and stress management, things like meditation, music therapy, mindfulness. This could help build resilience, and it complements the behavioral and educational interventions that are already suggested in ASD. And on top of all of that, we could encourage support systems and integrative care. Parental support networks should be encouraged, interdisciplinary communication between care providers. As the parent of an autistic daughter, I know firsthand the isolation that comes along with an ASD diagnosis, not only for me, but also for my daughter. So if I could recommend one thing, it would be support systems. That alone would be so beneficial to both caregivers and ASD individuals. In conclusion, probiotic supplementation consistently improves gastrointestinal symptoms in children with autism spectrum disorder. Behavioral benefits appear possible, but they're variable and strain dependent. Probiotics should be viewed as a supportive, adjunctive strategy rather than a replacement for established therapies. Future research should prioritize larger, long-term, randomized controlled trials and personalized intervention strategies to clarify the optimal protocols. Thank you so much for joining me,